years ago, but enough to be recently chatting back and forth about specifically, but not exclusively, ACL injury, ACL mechanisms, ACL rehab, ACL prevention, all that is ACL, which he is definitely an expert at. Biophysics, biomechanics, sports medicine research. And as you all know, I'm fond of the research. I'm not fond of anecdotal evidence. I'm not fond of I think, I like, I feel. I want to make sure what we're doing is evidence-based and up to date. So he is the perfect guy to talk to. We've conversed back and forth. You saw his name across the presentation I gave a number of times. And now you have this guy in front of you. So when you want to ask questions, Tim, I don't know how you want to go about doing this. You want to take questions as you go, or you want to present all you? It's your show.
Yeah, why don't you let me go through it, and then we'll take questions at the end.
Okay. All right. Well, then, without any further ado, as they say, Dr. Timothy Hewett.
Well, thanks very much, Bob. So what I want to talk to you about today is my system, which I call the 5P system of preventive biomechanics. And the screen shows you 5P is personalized, preventive, predictive, performance programming. I put this talk together for you all. Know these are two of my students, Carmen and Katie. As you can see, they're identical twins, and they were in our prospective cohort studies in early 2000s, and basically both of them tore their ACLs around age 16. And then Carmen on the left, who is shown getting her MD PhD out of our lab, ended up rupturing her graft very soon after the surgery, and Katie ruptured her graft, had a second tear long after, about in the next decade after she had her ACL reconstructed. Now they're about 14 years out. They're about 30 years old here, and they both had cartilage resurfacing procedures. The problem is Carmen and Katie are more the rule than they are the exception. So looking at this problem in my lab at one time at Cincinnati Children's Hospital, we had 6 people in the lab with 2 ACL injuries. And that first one is rough. If you have another one, it gets into your head and makes you want to try to figure out for the rest of your life how to stop this from ever happening again to you or anybody else. Now, what we use is this approach I call preventive biomechanics. And we study systemic exercise, neurologic injuries, cardiovascular. I'm going to show you some of the genetic data in the musculoskeletal area of ACL injuries. But basically, we use a multi-pronged approach of screening, risk stratification, and intervention. And we get everybody in the athletics department and the medical system involved. So what is this 5P evidence-based approach? Well, it's 5-pronged. First, we look at the mechanism of the injury that we're trying to reduce the risk of. And we do that based on looking at video of performance and actual injuries. We do screening, which is very personalized to the athlete. We use that screening to develop risk stratification tools, to develop predictive profiles for relative risk. We use targeted training based off those risk stratification profiles in our programming. And then we use preventive interventions, both primary prevention and secondary and even tertiary prevention based off these risk stratification and mechanistic tools. So ACL injuries, which I've been studying for the last 30 years now. If you look at the mechanism, and I challenge you to find me a video that doesn't have this aspect to it. So the body has this lower extremity valgus. We call it knee abduction. And you say, why is it abduction? Because the knee's diving into the middle. It's because the distal tibia, if you go from the ground up as we do in biomechanics, is abducting away from the midline of the body. But the knee itself and the hip are adducting and collapsing inwards. This happens with relatively low knee flexion when the foot contacts the ground, most of these injuries happening on a single leg on a flat rotated foot. So what that flat foot means is you get high force. You can listen to this on the court or on the field. Somebody lands with that flat foot, and that's what you hear. The slap of the foot is what you hear before the pop of the ACL, and often the foot's rotated. The center of mass is away from the foot base, so she's lost control of her trunk, mainly because she was perturbed up high with a bump from the player on the right, and this leads to an uncontrolled motion of the trunk and the core. And that ground reaction force from the foot is reacting from the floor to her center of mass, which is about the umbilicus area. And once that ground reaction force goes lateral to the hip and knee joint, it creates a torque, a force times the distance to the joint center, that's collapsing the hip and the knee in. Now, if we go specifically at the mechanism, if we zoom in on her knee, what you see is three aspects to this mechanism. So let's say this is my lateral knee, my fibula. What you have is this knee distal tibial abduction, anterior translation of primarily the lateral compartment, and because it's primarily lateral, you're getting internal rotation of the tibia relative to the femur, all applied very rapidly. Bam, the ACL ruptures. So how did we get at this mechanism? Again, this is about 30 years of work I'm showing you here, but basically what we use is whole athlete in vivo testing. We send that data from athletes, risk profiles, into cadaveric models, and then we build cadaveric computer in silico models based off both in vivo data and in vitro cadaveric data to get at the exact mechanism. We also use actual MRI imaging of the injuries, and what you can see post an injury is when the tibia comes forward like this and internally rotates, what you get with that combined adduction is when you get that bone bruise is where the bones hit high impact. The tibia is forward, internally rotated, and what you get is this combination of high impact bone bruises right at the point of injury. So they're forensic. They leave a footprint of how exactly the injury occurred. And it's just like that on the posterior lateral tibia, anterior lateral femoral condyle. And that basically shows you that's a forensic reproduction of the mechanism. So these bone bruises ID the mechanism. Then we can build based off our cadaveric models and these imaging models, models that show us this is exactly how her injury occurred. And from that, then we can move that model into an in silico model and see how the ACL tears. And basically what we've shown is this repeatedly. You get this anterior shear along with tibial abduction, internal rotation. They all strain the ACL. Well, people say, how do you get just tibial abduction and you're not tearing the ACL first? Because what you're doing is you're getting the tibial abduction combined at the exact same time with anterior tibial translation and rotation, and you're going around the MCL. And what we show is if you combine all of those together at the same time, you're really stressing the ACL and minimally stressing the MCL and rupturing the ACL. And if you look at any reproduction of, say, the pivot shift mechanism, so that the patient's lying in lateral decubitus, you're basically, what you're doing this is the most specific clinical test for ACL deficiency, and is the pivot shift test. So what the examiner is doing is applying knee abduction, internal rotation, and anterior translation force and reproducing that motion that occurred. That shows you that those combined motions, the most clinically specific test for ACL deficiency, are reproducing again that same injury mechanism. So there's massive amounts of evidence for this injury mechanism: coupled tibial abduction, anterior translation, internal rotation. So what we need to start thinking about is how do we prevent an ACL injury from occurring? Now, if we go back to this, if you look at the mechanism, anything that we can do to prevent these four things from happening, this valgus knee abduction, low knee flexion, single foot on a single leg on flat foot, center away from the trunk base, anything that we can do to prevent these things from occurring in the body so that they don't occur, this abduction, translation, and rotation of the knee, are going to help prevent an ACL injury from happening. That's why we're going to focus on the mechanism, and that's where we focus all of our exercises. Again, in vitro data, cadaveric studies, valgus simulations, computer simulations, in vivo simulations. There's literally hundreds of studies that show this dynamic valgus mechanism is what causes an ACL tear. We have to prevent that dynamic valgus mechanism at the hip and the knee. So that's the mechanism, is this combined rotation. Now let's watch an athlete land and tear his ACL. What you see is this is Rashawn Rondo playing for the Celtics. Single leg, valgus, extended knee. Now what we translate these issues to are neuromuscular imbalance patterns. And this is indicative of a leg, ligament, and quadriceps dominance pattern. And I'm going to talk next about how we get into that. Now, what we did were coupled biomechanical epidemiologic studies. This is at Ohio State. We actually covered all of the Ohio State sports in the 2000s. And basically what we started doing is when we looked at these athletes and we saw this mechanism of injury, we started taking these preseason measurements and started seeing these neuromuscular imbalances in people that were going to go on to prospectively a subsequent ACL tear. So if we look at the mechanism directly relates to these parallel neuromuscular imbalances that we measured prior to these athletes being injured. What we saw was athletes that have high risk of an ACL injury demonstrate, related to this knee abduction problem, what we call ligament dominance. What I mean by that is, instead of using their musculature to absorb and dissipate force, they allow the force to put their knee in that dynamic valgus position and then load up the ligament, using the ligaments as the restraint. That's not what ligaments are for. Ligaments are for holding the joint together. They are not for absorbing and dissipating force. This low flexion, landing in relatively low flexion at the knee, this is a sign of a neuromuscular imbalance we term quadriceps dominance, and I'm sure you all are quite familiar with quadriceps dominance in athletes. Athletes that have massive quadriceps and are way underloaded on the posterior chain, not only strength-wise, but recruitment-wise. Then single leg dominance. All athletes are leg dominant to some extent. What you see is greater leg dominance in force production, strength, balance in athletes with greater risk of injury. And then you'll see this increased lateral trunk motion. And this is what we term trunk dominance. What it's really about, though, is that lack of core control, where when you hit the ground and your body twists, you let that trunk move in excessive amount of motion and swing that center of mass away from the foot base and lateral to the knee and hip joints. So we did this. We showed this in screening for prediction of athletes, where those that went on to a ACL injury compared to subsequently uninjured athletes is they had about 8 degrees of more abduction, about 10 degrees less flexion. So again, this happens in both planes. This is how the musculature in flexion extension absorbs and dissipates force. If you go into frontal plane and allow a lot of frontal plane movements, the frontal plane musculature does not absorb and dissipate force well. If you just look at these X's are those that went on to an ACL tear, if you just focus on them, what you'll see here in this young active population is somewhere between half and 2/3 of these kids are at relatively high risk of rupturing their ACL during landings. So again, we have to get back to the mechanism, and then we have to focus on those neuromuscular imbalances that directly contribute to those mechanisms. And then what we have to do is ameliorate or decrease the relative imbalances present so we get less of this ACL mechanism in these individuals. So this is a bit of a laugher here. I'm calling this my favorite sport. What you'll see occasionally, there was a soccer player in Italy this past weekend who did the same thing. He jumped up and landed and kind of did a celebratory on both legs. The point is, if you have enough force and if you allow that valgus collapse, even with some force on both legs, you can still rupture your ACL. As you see, her left ACL just ruptured. She landed with a really flat foot as well. So even in an athlete like in the lower right in gymnastics who can exquisitely control their center of mass relative to their foot base, if they lose control of that center of mass relative to their foot base, let that trunk go lateral to the hip and knee joint, ACL pops. Now this is team handball. I'm guessing most of you are familiar with it. But this is something like would be similar. It's lower. It's not quite as high an incidence as Aussie rules football. Aussie rules football has the highest incidence of any sport because basically, like team handball, as you can see, when these athletes are jumping up, they're reproducing, they're recapitulating that injury mechanism. They're going up, trying to avoid the defender. They're putting their trunk lateral to their hip and knee joint, and then they land on a single flat foot and they get that knee abduction torque at the knee, that rapid collapse, anterior rotation, internal rotation, abduction of the tibia relative to the femur. They tear their ACL. This is what it looks like in the laboratory. So we're doing a drop vertical jump screen test, which we've done now and validated over 25 years. And basically what we do is we put a target. She's dropping down, reaching target set at her maximal vertical jump height of basketball. And what you see here is she lands unevenly. The forces are unevenly, flat-footed, very high force on the right side. It's lateral to the hip and knee joint, collapsing her knee in, and very asymmetric, very leg dominant. So this would show ligament dominance, leg dominance. She doesn't go into very much flexion, quad dominance, and again, this lack of trunk control and trunk dominance, which leads to this high ground reaction force and collapse at the hip and the knee. Again, let's go out on the court. Different athletes, same problem. Quad dominant athlete, what he does is he lands within a very extended, he's activating his quadriceps, extending that knee, and he pops, see how far out he is, and he pops his ACL. See how flat that foot? Very high ground reaction force. It's creating that knee abduction torque that tears his ACL. Now what we've shown with 5P, with screened athletes who go through a screening process, and we develop a risk profile, and then we target their training toward those parts of the mechanism, those neuromuscular imbalances that lead into those mechanisms. Same athlete, same targeted athlete. Now she drops off the box again. She now can jump higher. We've shown with these tools that we can increase jump height. She can not only jump higher, the ball's set higher, but now she can land with good frontal plane control. The ground reaction force is going through the center of the knee joint, so it's quite low. She's flexing her hips and knee, keeps her trunk under control. Ground reaction forces are way down and they're symmetrical and they're not pushing her hip and knee in. So again, critical analysis and feedback. If this athlete is not aware that she does this when she's trying to rebound that basketball, she can't change the way she moves. So that's important. But also what's really important is to know there's both passive and active restraints. He just dislocated his knee. This is a biomechanical analysis. Now, that's not an abduction moment, that's an adduction, but you can see just a small amount of movement of his trunk can create a large torque that puts a huge adducting load on the knee joint. This is a series of studies we published back in the late 2000s. This was a group of over 300, well, just under 300 athletes in this one that we tested at Yale. So these were all Yale, both male and female athletes. And what they were doing here is they were on basically it's a bar stool. And basically what we do is release that bar stool, we move their trunk 20 degrees, and then just using their sense, their trunk sense, they're supposed to position themselves with their eyes closed back to where they think they originally were, and they press a button to say, I'm back to where that step motor originally had me. What we showed was that these core stability deficits predicted those who were going to go on to a ligament and an ACL injury. And again, if you look at KP here, injuring himself, the lateralized trunk, that trunk dominant movement, he's perturbed, the trunk's out of control, he ruptures his ACL. Again, this is at the point where this young athlete, we did a whole series of every video we could find of every athlete tearing their ACL, and basically every single time, lateral trunk movement, bring the center mass away and lateral to the hip and the knee joint relative to the foot, high ground reaction force, high torque. And basically this happens as kids grow and mature. So the kids you're working with at college level, they're already at deficits. So they've already had the growth of these longest levers, higher forces. You have to remember your big predictors are your levers, your bone length, and your body mass. And we'll talk a little bit more about that. But with risk screening and subject identification, this is with a very intricate 3D motion analysis system where we can track the torques. When her bones go red, that shows that's higher than the torque required to pick out someone at high risk of an ACL tear. Then what we did in conjunction with this, with full 3D motion analysis, we did simple 2D analysis and used a dynamometer for strength to assess relative risk. This is a risk screening tool in a volleyball player. She has a long tibia length, which gives her, that's the lever that's torquing the knee joint. She has on one knee, she has 3 centimeters increased valgus motion. She has limited knee flexion range of motion, so she's not using that musculature in the sagittal plane to absorb and dissipate force. Mass is always in the equation. The taller the athlete, the greater the mass, the greater risk they have. And then if they have decreased hamstring posterior strength and muscle activation compared to quad, they're at greater risk. And when you put those all together, we can basically predict with very high accuracy their risk of going on to an ACL injury. Actually, we put her in the high risk, and her actual knee load was 50 Newton meters of torque, which is almost double what's required to put her in the high risk zone. So what's the good news? We've been talking about all the risk factors and how these kids show all these muscle dominant patterns, neuromuscular control problems. Well, what's the good news? Well, we published the first study in 1999. This was a follow-up meta-analysis of all the existing studies at this time in the mid-2000s. And basically what we showed is if you address the mechanism, and here's how you address the mechanism, this knee abduction problem, this ligament dominance, with biomechanics and technique. This low flexion problem, power up the musculature, load, and especially in the posterior chain. Hammies, glute complex are absolutely crucial. Load them, strengthen them, power them up, recruit them up. Posterior chain compared to quad. Single leg balance, but we can start out with single low level balance, working towards symmetry, just a simple single leg balance. But what we're going to do is progress that into very dynamic plyometric repeat balance exercise. And then the core away from the center of mass, we're going to use core stability exercises, but not grandma and grandpa's core stability exercises. We're going to do very functional core stability training that includes explosive loaded movements. So there's evidence supporting landing and balance interventions in the effective interventions. So those studies that include plyometrics combined with biomechanical analysis and technique were all common components of every single study that reduced ACL injury rates. You need plyometrics, we know this, with a lot of biomechanical analysis and technique training was included in every single study that could prevent an ACL. This is a German study, and people will tell you, maybe this is amazing. The effectiveness of ACL prevention programs is absolutely amazing. In musculoskeletal, orthopedic, sports medicine type research, you don't see effect sizes of 50 to 70%. You just don't see them. Well, people will make claims, well, maybe only the positive studies actually get published in the literature. It's called publication bias. Well, that's why we use this, what's called a funnel plot analysis. Now, this is a 67, that's a 67% reduction line. This is our original study from 99. Here's all the other studies. What you show is that hugs that same reduction line very tightly, which means that amount is very precise and accurate. They also are all within this funnel, which shows this is not a positive publication bias. This is how you statistically test for that. So this is valid as well. It's valid as well as accurate and precise. So then a group from Australia and I worked together with this. Kate Webster is an expert in meta-analysis. And basically what we did is showed about 20 years after we published that first study, we looked at all the existing studies. There were 15 randomized controlled trials at that time. Initially in 1999, we showed a relative risk reduction of 50% for all athletes, 67% for female athletes, non-contact ACL injuries. 20 years later, with 15 meta-analyses. So this was a meta-analysis of all the meta-analyses in the literature, or a mega-analysis as we called it. It's actually, in Cochrane reviews, it's called an umbrella analysis. But what it shows is what we showed 20 years prior in a single trial. We could see in 15 meta-analyses, we can reduce by half all ACL injuries, by 2/3 non-contact ACL injuries in female athletes. So this is a massive breakthrough in what we've been able to do here. The problem we face is problems of compliance. Well, first of all, just getting them instituted, doing them properly, compliance by the coach and the athletic system, and then adherence by the players. That's where the real problems are. The real problems aren't in the programming, but especially if you can test those athletes, take them through a screen, risk stratify them, and develop specific program for your athlete that is targeted. Not only does that make the athlete give them better buy-in, that it's very individualized and personalized to them, it's also going to be more effective, and it's going to give them more motivation to do it. So again, what's the algorithm here? There are athletes at high risk of ACL injury, as we show in these screening protocols. The injury prevention treatment algorithm is technique, a lot of feedback, plyometrics, very dynamic, double leg to single leg plyometrics and balance training, and then dynamic, again, dynamic, powerful, loaded core and strength training. So program training components, biomechanics, safe and effective technique, a lot of biofeedback. Now, biofeedback is voice, biofeedback is sound, how loud their landings are. Biofeedback can be mirrors. Biofeedback, what's one of the most effective things we do now is cell phone video. Plyometrics, neuromuscular adaptation to stretch and speed. A lot of people don't do plyometrics properly. What you're doing is trying to decrease the amortization phase, the time from when you land to when you take off again. That's crucial that you shorten that period of the stretch shortening cycle, because that's going to not only make that jump more powerful, it's going to give you better control of your center of mass and better control of your joint centers. And then a lot of dynamic functional balance and strength work, functional speed and multi-directional power, and then core stability training, but not what you see on midnight infomercials. Kinetic chain control, balance, introducing perturbations. This is important because a lot of the times those trunk perturbations are introduced by other athletes chaotically. So what you have to do is introduce unknown, unexpected, unplanned perturbations into their dynamic training protocols. Again, this was a meta-analysis we did when there were 12 studies out there. What we showed is it favors somewhere between 50% reduction in all ACL injuries, 2/3 in non-contact ACL injuries in females. So again, how do we make that ACL less vulnerable? How do we effectively address the mechanism? Knee abduction with biomechanics and technique, low flexion with plyometric power, especially turning on the posterior chain, which you pretty much have to do if your plyometrics are done properly. Single leg on a flat foot, a lot teaching, number one, an athlete to listen to themselves land, how loud their landings are, teaching them to use their foot as a rocker, land on forefoot, rock back and forth, never flat foot landing, doing that symmetrically from side to side. And then again, center of mass control under perturbed conditions. I'm going to argue if neuromuscular training can increase, which we've shown in the laboratory, we show that it increases neuromuscular control of the joint and it decreases knee and ACL injury risk. You can bring up all the things you want, Q angles, turfs, everything you want. But if we can, with neuromuscular training, alter neuromuscular control and show that that altered neuromuscular control results in a decrease of knee and ACL injury, it means the mechanisms underlying this are primarily neuromuscular in nature. Again, there are other inputs here. I'm not saying this is the only thing, but they are primarily neuromuscular in nature. And the good news is they're modifiable. There's just endless data that shows abduction, internal rotation, and anterior translation are the cause of ACL injury at the knee joint. This is Shay Ralph. This is her third ACL tear. I was lecturing. I'm actually heading out to San Diego in a month from now to lecture to orthopedic surgeons at the American Academy of Orthopedic Surgeons, which is about 35,000 people. That meeting is the first week in September down in San Diego. I actually presented this at the Academy and said this was her third injury and she went on to 5 ACL tears. A surgeon in the back raised up his hand and said, "Hewett, you're wrong." And I said, "That's impossible. I've never been wrong." And he said, "Well, you're wrong because I just reconstructed her ACL a 6th time." So again, that athlete, think of how, and she led UConn to, I think, 3 national championships. I mean, just an amazing athlete, but we don't want athletes going down the road to 6 ACL reconstructions. So let's talk about the next big problem. And this is basically what has become the driving point of my work. As I alluded to earlier with Carmen and Katie, and as I alluded to in my lab with 6 people that had 2 ACL tears, most of them contralateral. So most people are going to tear the other side. Now, for the surgeon, the graft tear is the most traumatic because they say, "Oh, you've messed up my graft." For the athlete, to have both knees torn and reconstructed, that not only affects your physiology, your long-term bone health, it also affects you psychologically, no doubt about it. So this has been my passion for about the last 10 years, trying to figure out what is the relative risk? This is Derrick Rose tearing his ACL. Now, I don't know if you remember this, the Chicago Tribune, Chicago's a pretty tough sports town, and they just tore him apart because a year later, they were in the playoffs and he wasn't playing. And they said, what is this wimp? He's 12 months out. He's a full 12 months out and he's not playing. They put him the next season. He shows himself as a leg ligament and quadriceps dominant athlete. And they push him back. And what does he do? Like third game in, he tears his meniscus. So you're talking about a $22 million a year player that you're so worried about pushing back in to that very first game that he can, and then you're basically, you know, altering his entire career. So this was a series of studies that we did, basically trying to identify predictors of future second injury. And basically there were estimates that this was relative. The surgeons would say, oh, this happens maybe 5% or 10% of the time, but they didn't follow their athletes very well. Now, here's the problem. The ACL is not only this elastomeric, very strong elastomeric piece of tissue in your knee, it's also richly innervated. It has all 5 types of mechanoreceptors. And what happens when you blow that ACL apart, it looks like mop ends. And what you end up with is nerve endings that are ruptured and they're just torn apart. So here's my current hypothesis on this. I think what goes on is you have that sensor, so that all those nerve endings in the ACL, chock full, it's one of the richest tissues full of nerve endings, are not only sensing the position of the ACL, but also the force and load on the ACL. And then there are afferent, efferent, spinal level, very rapid spinal level feedback loops for taking force off the ACL. Well, you've lost that. So that sensor's gone. Does that sensor ever return? Probably not. There's very little evidence that it does. And even if it did, there's a little bit of evidence in dogs that there might be a little bit of nerve reingrowth into a graft. It wouldn't be finely tuned and calibrated enough to sense and have an afferent, efferent feedback loop that was effective enough. So what you've got is, I look at it this way, you've blown a fuse in your knee. Now, what you guys are doing over time is developing parallel circuits. Now, what that blown fuse does is it sends through the afferent nerve ending to the inhibitory nerve endings of the spine an on signal. It says, we've got on. So it turns the inhibitory neurons on, full blast, and they turn off the afferents. And that's why you get that rapid quad shrinkage. So the problem is that doesn't come back. When a surgeon reconstructs the ligament, that's gone. What you guys are doing with these athletes over time, and it takes time, is you're teaching them how to use other sensors, other nerve endings in the muscle, in the fascia, in the tendons and ligaments to sense that joint and control the force on the joint and the ACL again. The problem is that takes a long time. For the average person, that takes around 2 years, which is a big problem. And this lack of innervation and lack of sensation leads to what you guys see on the field, which is an unloading and stiffening of the involved joint. So what they do is they unload the involved side, the reconstructed side, and then they overload the contralateral side, which is a big problem. So again, we looked at athletes, and what we showed was, first of all, we had to do the epi. And we showed was in the first 2 years out, 30% of athletes have a second subsequent ACL tear. Now, again, the surgeons didn't believe this at first until a surgery group down in Australia This is Julian Feller and Kate Webster's group, showed the exact same number, because what they were doing is carefully tracking their athletes just like we were. Now their competitor down, so Julian Feller is like the ACL surgeon to the stars for AFL in Melbourne. Now the other surgeon to the stars is Leo Pincheski, and he's in Sydney. They're competitors. They don't like one another, never agree on anything, but they agreed on this exact same number. It's about a third in the first 2 years. So what are the predictors of this second tear risk? Basically what we showed is hip internal rotation and knee abduction moment. So again, that adduction of the knee and internal rotation of the hip and abduction collapse of the knee joint together predicted with very high accuracy. This is prospective studies. This was our screening done prospectively on who was going to go on to a second ACL tear. So at the hip, this is the hip internal external rotation moment at the knee. This is that moment that the ground reaction force is internally rotating and adducting the femur. What we showed was those that don't go on to a second tear have a positive value of this throughout landing and takeoff in that drop vertical jump test. Whereas those that do go on to an injury are actually in the negative, especially early on in landing when injury occurs. A very high negative moment, which is actually actively internally rotating, adducting their hip and their knee. These red boxes are those that go on to a second ACL tear, most often in the contralateral limb. And what you see is a very high predictive value for those that allow the ground reaction force to internally rotate and adduct their hip. This is Baron Davis tearing his graft. What you'll see here is just what I showed you biomechanically. Extended leg, quad dominant athlete, flat foot, and let's see what results in this in the frontal plane. Internal rotation of the hip, collapse of the hip and knee joint on that flat foot, tearing of the graft in a $20+ million player. Another example here, he's even in a Donjoy brace. He's all braced up, supposed to keep from anterior translation, internal rotation, and he's torn his graft that they tore his senior year prior to his junior year prior to his draft year. One of the best athletes ever to come out of college in the NFL, starting in the playoffs, tears his graft. They say, how do we know this could have happened? Well, let's go back to his combine on the left. What do you see here? He's doing a maximum broad jump. He's one of these athletes that has active dynamic valgus. Not only do they let the ground push their hips and the knee in that collapsed position, I hypothesize that these athletes, they're very often very powerful athletes. They're actually storing elastic energy by doing that internal twist and takeoff. But it puts that athlete at risk. So these young high-level athletes are risk. They've got a risk of somewhere between a quarter and a third. In AFL, they've shown in young athletes with hamstrings grafts, 40% second tear rates. So what we've done is a series of studies across many institutions looking for these kids and screening thousands of athletes. We're looking for her, the athlete that uses her knees like, not him, he uses his knees like hinges on stiff muscular springs, but the athlete that uses her hips and knees like ball and socket joints, not absorbing and dissipating that force in the sagittal plane, but allowing that force to torque their hip and the knee in the frontal plane, load the ACL and tear the ligament. So what we showed was in that group of athletes who goes on to a second ACL tear, either on the contralateral or reconstructed side, regardless, those that allowed the ground to push their hip into a net internal adduction moment had an 8.5 times greater odds of having a second ACL tear. If they had that 2D, just with 2D camera, frontal plane knee motion, that valgus collapse, 3.5 times greater risk. A side-to-side difference in relative ham versus posterior chain activation, 3.5. So in other words, they were quad dominant. And then those that showed a stiffening strategy on the involved limb, 3.5. Using just these 4 variables, we could account for 94% of the variation of that model. This is the receiver operating curve, basically showing that we could predict with very high sensitivity and specificity, 90% sensitivity and specificity, with a C statistic accounting for 94% of that variation with just those 4 variables. Let's talk again about this knee as a proprioceptor. She's torn her ACL, and we're asking her one leg at a time to sway back and forth at a slow speed and a fast. This is the fast. This is 6 hertz per second. But she's got a biofeedback screen in front of her with that rectangle that's moving toward and away from her face. And we're asking her to sway first at a slower speed and then at a higher speed. And then we're looking at the sinking of all the lower extremity joints, the ankle joint, the knee joint, and the hip joint. What we did is ask them to bring in an uninjured control. Usually it's a player from the same team, usually same position. So we want same sex, same height, same weight, so we can control for all these biomechanical variables. So this is what their partner looked like, their fellow hitter off their volleyball team. Looks when you go from 0.2 hertz to 0.65 hertz, where she was going, what you do is you get a flipping 180 degrees of the sinking of the joints. When you're swaying real slow like that, what you do is you sink for example, the hip and the ankle together. They're moving at the same angular momentum in the same direction. What happens when you go faster, though, you unlink that, and your hip and ankle go 180 degrees out of phase with one another. This is what someone with an ACL reconstruction looks like. It looks very different. At the slow speed, because they've lost those sensors, they don't sense that ACL in the joint as well. There's more variability and more error even at the slow speed. And then when they go to the fast speed, because they don't sense the joint well, they lock the degrees of freedom of the joint down. They stiffen that joint. And then here's someone who's going to go on to a subsequent second ACL injury. It's exactly the opposite pattern. At the slow speed, it's 180 degrees out of phase. They don't sense the joint well. And when we make them go faster, they just lock the joint down because they can't sense it. And this is a nonlinear dynamical systems modeling approach to this data. It's called cross-recurrence analysis. And basically, this is what controlled people look like. They have very continuous, very linear sinking of their hip and knee and ankle joints. What happens is once someone's ACL reconstruction, that sinking, that linearity starts to break down. And then what happens to someone who's going to go on to a second ACL tear, that linearity and continuity are absolutely gone because they don't sense that knee between the hip and the ankle well. So how do we address this? As we did in primary prevention, what we have to do is look at all the problems. This varied success for return to sport, it can be quite low, especially in high demand sports like AFL. Basically what they reported was only about half people are back to sport at a year, and only about 80% get back at 2 years. So we proposed some time ago, hey, there's all these deficits that you see can last out because you're developing these parallel components. It was sort of tongue in cheek because we knew people weren't actually going to do it. But in order to deal with all these deficits, you might have to wait out 2 years. Well, you say, well, no one's going to do that. In their cohort, the majority of people, about 48% of people, didn't get back until 2 years. But you see all these stiff knees and these frontal plane changes and these lower extremity asymmetries. You see this high prevalence and incidence of OA. We just showed at least a third at 10 years have advanced OA. That's a huge problem. That's because they've got this altered motion and this stiffening of that involved joint. And then you've got this second injury rate of a third plus. So what do we have to do here? Well, we have to add our 5P neuromuscular training. We have to do our screening. We have to look at their relative risk deficits and then introduce them into their rehab. So this problem with this hip transverse net plane moment, we know what to do with that because it's trunk dominance. We've shown you what to do about that. And we know what to do with this knee abduction problem. It's ligament dominance. This asymmetry is quadriceps dominance. This decreased postural stability is this stiffening strategy. We can get at those following these guidelines, address the trunk and lower extremity in 3D, use independent and combined exercise, use a phased-based progression approach. And I can't say this enough. Training is testing and testing is training. Keep good records, phase your approach back, progressively add degrees of freedom, volume, speed, perturbations, and make sure you have good control before you have progression. Otherwise, what you end up with is a torn contralateral ACL, just like occurred right there. So again, lateral control, frontal plane control is very important. So you're going to do a lot of plyometrics. You're going to start out phase one is going to be double leg. You're going to progress it into single leg, and then you're going to bring it back into functional sport specific in phase 5. Again, trunk stability. We're going to start very proximal. We'll start on a BOSU, and they're working out on their knee just to get that proximal trunk control. And then we get them on a Swiss ball, and then slowly we'll progress them up onto their foot. So going back to where we started, we've got this whole system of preventive biomechanics. It's screening, it's risk stratification, it's surveillance, it's targeted intervention. Now, this is Carmen and Katie's genetic profile. This is a genetic study we did where they had a family picnic. And so we had a fun picnic table at the family where we took blood from every living family member of 42 individuals. This is Carmen and Katie, these two identical twins. You go up one generation. This is their dad. This is his triplet brothers. All three of them had bilateral ACL tears.
Yes.
Big problem.
Hey,
I've written
Tim,
a book. I've edited a book on this subject. I do not make a dime off this. This all goes to AOSSM for ACL research. And this is about 25 years worth of research I just showed you, and a lot of people were involved. So thank you for your time, and I'm happy to take your questions at this point.
Hey, Tim, first of all, you have somebody trying to get in right now. Rachel, I think you're going to have to let her in because you're the host.
Okay, let's see.
Should be in the participants.
Participants.
The very top, it should say let them in or something.
Admit.
Yeah.
Yep. Okay. I think is that everybody now?
Yep.
Okay. Any questions? Is all that heavy duty biomechanics clear as the California air?
I wish the air was
Hewett,
clear.
Dr. Hewett, I just want to say thank you. This is very helpful. I've got a young staff, and anytime we can get, a lecture like this to kind of reinforce what, we need to look for to help prevent these injuries. And I think it's, been great. Bob, thank you for, organizing this to get, sports performance, sports medicine all together. Because I think if we're working more cohesively as a team, we can kind of, work together, help prevent these injuries. So, thank you for, your presentation. It was very helpful.
And again, that's absolutely the goal of preventive biomechanics, is using that team, the strength coach, the athletic trainers, the physical therapists, the physicians, the surgeons, and the scientists, getting everybody on the same page and interacting together. And that's why I may have hit the same points again and again and again, but I want to bombard you with the evidence that shows that we can make a difference with these athletes. But it takes everybody. It takes a team for sure.
I do want to ask in terms of corrective exercises and cueing, because I got from your lecture that, cueing and that feedback is might be the most important thing to correct that the biomechanical deficiencies. What, I guess, cueings would you offer, and what, I guess, muscle groups would you emphasize? I know you mentioned the glutes and the hamstrings, but are there certain like kind of bang for your buck exercises that you would emphasize more, and so forth?
Yeah, so from a cueing perspective, it's absolutely important. So visualizations, landing softly, auditory sensations, same thing. When you tell an athlete to land softly, to roll their foot, now what you're going to do is you're going to start out with a internal focus. And you're going to say, your foot is a really effective rocker. You need to land on the ball of your foot, and then you need to rock it. But over time with that, you become more external focused, because they can't focus on their foot and their hip and their knee when they're out playing soccer. So you're going to transition that into more of an external focus. An external focus like, okay, we're going to test your max vertical jump, and you just focus on their max vertical jump. And then what you say is, man, that land, and people, when they're doing their max vertical jump, no matter how they're testing it, they're just focused on that jump. And very often they'll land poorly, right? And they'll land with a flat foot, which is really dangerous when you're doing a max vertical jump. Actually, I had a volleyball coach once that I went out and worked with him and his kids. Well, I worked with him, and then he was working with his kids, and he said, this is what Dr. Hewett taught me not to do. He went up and did a volleyball block and landed flat-footed and popped his ACL. So don't show people by, this is not what you should do at all. But start with cueing, landing soft as a feather, using your body like a shock absorber. Starting out rolling your foot, but auditory cues, you want a very soft landing. We'd start out in the early days of this, when I was writing my grants in an office just right off the lab, we'd bring the new groups of kids in. We'd bring whole teams, 30, 35 kids, training out on the, it was a nice rubberized giving floor, but it literally sounded like cattle. And I would come out of my office and I'd say, I'm writing grants here. I need to focus. Be quiet. Immediately, everything quiets down. How do they do that? They roll their foot. They flex their body in the sagittal plane. They have the neural networks to make that happen. And I think that's key too. So exercises. I love Russian hamstring curls as starters. So those are not on your foot, but that's going to really power up your posterior chain. Now, a lot of athletes aren't very good at doing that. If you want to see an amazingly good Russian hamstring curl, look up Adam Archuleta Russian hamstring curl. He used to do them when he was playing for the Rams. He used to do them with two 45-pound plates with perfect form, both eccentric, concentric. Now, what we do is, because most athletes are not Adam Archuleta, is we put their knees on an RX mat. We usually have a BOSU in front of them so they don't do a face plant on the floor. And then we use those bands, the thick ones, across their chest and underneath their armpits. And that way you get that full eccentric, and then you get the concentric in as well with that assist back. But the focus has to be on neutral pelvis, absolutely perfect form. Same thing, Romanian deadlifts, single leg Romanian deadlifts. But then you have to transition those strength and power exercises into plyometrics that utilize the same movements and the same musculature. Plyos are a key part of this. So you start out double-legged, simple, squat jumps, but you're giving those kids, and you're starting out with an internal focus. Again, roll your foot, And then what you do over time is you're having them doing squat jumps while you're throwing balls at them. So taking the focus externally, where you're introducing perturbations. Then you put them up on a BOSU where they're doing squats on the BOSU, where you can even transition once over time is a squat jump on a BOSU with perturbation. So what you do, you constantly make it more chaotic and move it out from more of an internal to an external focus with internal cues and then external cues.
Okay, thank you.
Steve, once you hop back in there, let him tell Tim what our screen looks like right now, and let's see what he can add or think about. Are we doing? Could we do more or not? Let him know what we now implemented.
Yeah. So with our ACL tears, I'm sure you're familiar with Dr. Chris Powers, and I've had a relationship with him for about 6 or 7 years, and
yeah,
we've done we've utilized him for his 6 movement screens, which is doing a step down, a drop jump, a decel, a triple jump, a lateral shuffle, and an L cut. And then he's got his scoring system looking at the the trunk symmetry, pelvic symmetry, knee valgus, and then shock absorption, and basically the hip and trunk flexion angles. And then based off of that, we put them on a scoring system, and we've had pretty good success with that. At this point, we're trying to implement a quick screen, and where we can identify the valgus load on our lower extremity dominant student athletes. And so we just kind of took 2 of those tests, the step down and the drop jump, and just looking at it from the front and looking at valgus. So we can screen as many people as we can, because we're just doing it with an iPad, and we're just trying to identify, those student athletes that have mild to severe valgus. And then from there, we're putting them on a lower extremity corrective exercise program.
Yeah, so I know Chris well. He and I have lectured, together for years. It's actually, he and I come at it from very different angles, and we basically came up with very, very similar answers, which tells you, that's consilience of data. That's when you know that you've gotten it right, when 2 different people using totally different paradigms come up with the same answers. So I agree with the things Chris does and what he looks at. I would add, so in those predictive factors, that there's that hip internal rotation and that knee valgus. You can pick that up with the drop vertical jump. I think you need to add in those other 2 factors. The one is that stiffening strategy, and we usually do that on a balance test, preferably either on a force plate or on an unstable, even on a BOSU. If you want it quick, I would do it for 30 seconds on a BOSU and count the number of touchdowns, one side versus the other. That'll give you an idea of their balancing ability and whether they're using that stiffening strategy at the knee. And then the other thing, the 4th factor I would look at is some measure of strength and power. And there's lots of different ways to do this, but posterior chain versus quads, some measure of that incorporated in there, because that's pretty key. And symmetry side to side in each of those.
Okay.
So we on that step down, it's essentially a pistol squat, Tim. So we have an erect trunk. I'm not a big fan of that, because we're not, we're not really looking at the posterior chain then, are we?
I have to admit, I'm not crazy about the step down either, because it hasn't, I know Chris incorporates it. That's a physical therapy thing. That's what you get in most physical therapy schools are going to teach that. And I understand Chris is a PT. It makes sense. He comes out, and it's a simple, straightforward thing to do. I don't think it's dynamic enough. And no, I don't think it engages. if you do it super well, if you know how to do a pistol squat where you're coming down and you can almost touch your butt to your heel, then I think it might have a little more validity, at least, you know, posterior strength versus anterior. But most people can't do that well at all. I'm not a, I don't think there was a PT out of Wisconsin that tested that, and even he showed, he was mostly doing it for runners. Even he showed that, John Wilson is his name. He didn't show a lot of, you know, internal or external validity to that single leg test. Most people don't do it that well either.
And Dr. Hewett, on the BOSU test, are you having them on the flat surface down and their foot's on the you know, inflated surface?
We do both, but
Both,
usually
yeah.
what we do is we start out flat surface up on 2 legs. We start from there and then progress that to a single leg, but then we use the other side in the same ways too.
And then
we
as
use
far
both.
as
whenever something becomes relatively easy, you progress it to a different way to make it more difficult.
okay, and then is there a standard in terms of like number of errors within 30 seconds that is, you know, low risk versus high risk?
There isn't a standard, but I'd say within 30 seconds, what you're looking for is a differential of more than, say, 3 or more step downs, you know, or touchdowns.
Okay.
But that's a nice little test to do, and it's usually pretty diagnostic.
Okay.
And it's simple, relatively quick.
I have a question for you, Dr. Hewett. What's your experience with seeing, you know, instead of a complete rupture of an ACL, but more of an avulsion of the tibial spine, whether that's with a suture tie down or just rehab, strengthen it back, and, you know, with a, you know, then from there, they may be going off and re-tearing their ACL into full tear. Have you seen anything with that regards?
Yeah, so the tibial advulsion, yeah, they happen. They more often happen in kids than they do fully mature adults, because in, you know, the kind of orthopedic common knowledge is in kids, bone is weaker than ligament is strong.
Mm-hmm.
So the bone very often gives way. Usually, if it is a true bony avulsion and the ACL is intact, that means all you should have to do is take a screw or two and screw that tibial spine back down to the tibia, and you should have your sensors intact. Those should have some of the best outcomes of any ACL reconstruction. That's your best case scenario. If you have a follow-up injury to that, I don't know. That's tough. That's a difficult, you know, but I still think there's a big advantage of having a tibial avulsion over a mid-substance tear.
So you wouldn't necessarily consider 2 injury, you know, the avulsion, have this, you know, screw in, and then a tear, you wouldn't find those to be a injury of itself, or
that should be, if it was a true tibial avulsion and it was just bone and the ACL, the ligament was not ruptured at all. If that's the case, again, which normally happens in younger kids, if that's the case, if the surgery, again, usually they use a couple of screws. If that's the case and there's an ACL tear after that, that should be 2 totally separate injuries.
Okay.
Unless you had a bone failure, you know.
Right.
But yeah, if later you had a mid-substance tear of the ACL, that's two totally separate injuries. It should be.
All right, thank you.
Yeah.
Dr. Hewett, I had a question just in terms of the type of ACL reconstruction. Through your research, were you able to identify the gold standard in terms of, say, patellar tendon, autograft, allograft? What gets the best results and least amount of re-tears?
Yeah, so this is, I'll try to lay out the data for you. In young active athletes, allografts are an absolute no-no. Allografts fail at a multiple times rate compared to autografts in young active athletes. If you're going to use an allograft, it should be someone in like the over 40 range who's going to maybe play, a little club tennis. Not a good idea in young active athletes, first of all. So allograft should be and there's a lot of data in the literature to support that statement. Next, autograft choices. Hamstrings fail more than quadriceps tendons do. That's also clear in the literature. They also, if you look at the literature, they fail more often in young females than they do in males. That's another problem because very often for cosmesis and for patellofemoral reasons, the tendency is to overuse the hamstring graft in the females. The problem is they stretch out more in females, they out and out fail more in females, and females, especially like a female soccer player, really needs those medial hamstrings. So if you look at females who tend to be very quadriceps dominant, when they do turn on their hamstrings, they tend to use lateral hamstrings. But when you tighten down your lateral hamstrings and don't highly activate your medial hamstrings, what do you get? You get this. So you get valgus. So that's a problem. So to have somebody who's already quad dominant, who way underutilizes her medial hamstrings, and to take those out as the graft preferentially, I think is a really bad idea. Now, what surgeons will say is, yeah, you're truly robbing Peter to pay Paul with autographs. That's the problem, right? You're robbing Peter to pay Paul. What surgeons will say is, well, I'm not going to use I worked in the group with a group in Cincinnati for decades, and the same guys and lots of our guys and our group at Mayo, our group at Mayo were all trained to do, none of them, they rarely did allografts. They did allografts on multi-ligament knee injuries, definitely not in young active athletes, but they all knew how to do a hamstring graft, a bone tendon bone graft, and a quad graft. Quads are there's a little more learning curve to that because you've got this big chunk of quad ligament, and because you've got multiple, you've got four muscles coming into there, a lot of the fibrils of the ligament are not aligned real linearly and straight. So it's kind of difficult to determine how you're going to cut that out. So anyway, so they all knew how to do that. But the guys that I worked with for years in Cincinnati, who were the Bengals teams doc, they would say gold standard. You will never see a hamstring graft in an NFL player. And you'll say, why? Well, I just trust bone tendon bone graft. That's for a big male, strong football player. I want a big, strong, reliable graft. And so I'd say to these guys, so you're telling me that you wouldn't put a hamstring graft in an NFL player because it's not strong enough, but you're going to put that in a female soccer player who constantly has to internally rotate her foot to move the ball around? That's what your hamstrings do. your hamstrings internally rotate your tibia. So your medial hamstrings, that is. So this has been an ongoing battle, but what a lot of surgeons will say is, again, well, you're gonna, at the same time, if I put that female athlete and I take her patellar tendon and she gets anterior knee pain, I'm gonna be dealing with that for the rest of her life. I like the quad graft. Now, some people would argue with me and say, well, that's just because the quad graft hasn't been used long enough that all the negative data has come in. There probably is some truth to that, but the quad graft has been around a lot longer than people think. I think it's not such a bad. So you're robbing Peter, right? But Peter you're taking from someone who is a quad dominant athlete usually. Okay, so that quiets the quads a bit. You also have a lot more tissue to choose from. You can come up with just about any size and shape of graft that you want. You're not taking those medial hamstrings, and you're not going to exacerbate anterior knee pain with it. And most of the data that's come out recently on quad grafts is very, very positive. A lot of people a lot of surgeons that are friends and colleagues of mine have transitioned over from either a hamstring or a bone tendon bone or a allograft. So I'll say this in order from lowest. Allograft is your last choice, hamstring, bone tendon bone, and then some people would say quadriceps is equal, or I would push it maybe a little ahead on graft choices.
All right, thank you.
More than welcome. That is based off evidence, but a lot of surgeons who I have debated this with would say that's just my opinion. That last part about quad versus bone tendon bone is a little bit of opinion because the data is really not out as far as it needs to be yet.
With that, Dr. Hewett, have you seen or heard much research regarding a hybrid graft, both allo and auto hamstring being used to repair an ACL?
Yeah, I think that is a mistake. With my time at Ohio State, we had Bob Magnuson, who's a very fine young orthopedic surgeon, and he trained in France. And in France, very early on, Lyon, France, they were trying those hybrid allografts and autografts. And his data, both French data and some data he did during his fellowship in the States, showed that that allograft tissue, so you're using cadaveric tissue and mixing it in and tying it together with live tissue out of the same individual. What he showed was that there's a negative effect of the interaction between that dead cadaveric tissue and live tissue, maybe some kind of post-mortem chemicals, something that actually decreased the viability of the autograft part of that graft. And what they would get is, they get graft shrinkage and tunnel loosening. I think that it's only been a couple of studies. I don't think that's a good idea. I would put that option down there between the hamstrings and even closer to the allograft.
Gotcha. Okay. Thank you.
You're welcome.
Dr. Hugh, I got a couple of questions in terms of practicality of what in our level, if we don't have like a Biodex or some kind of isokinetic machine, how can we kind of, from a practical sense, of do a quad to hamstring ratio?
Yeah, it's tough. I did those studies back in the 90s. So I've used Biodexes for years, and I even like using high speed. Most of our data is at 300 degrees per second because it gets that neural activation along with strength, especially for the hammies, because it's difficult to do ham curls at that speed. So I would say do what you can do. So if what you got is a leg extension, leg curl device, that's what you use. I can just say that's not, you know, if you compare and come up with a rep ratio or a strength ratio or a strength by rep or a, you know, maximum, you know, 1 rep max or 5 rep max, however you do it, it just, the problem is it doesn't correlate very well. But what I would say is do what you've got, you know, and even if it's just a leg press and you're comparing one side versus the other to look at strength asymmetry, do that. Because strength is, you know, I'm a former competitive power lifter, so obviously I think strength, and my bias is that strength and power are very important. What you have to keep in mind though, and when I showed you that, you know, when we are predictive equation, strength always comes out of the equation. It's always a predictor out of our 4 or 5 predictors. It's always one of them, but it's only going to account for about 20% of the variation. So it's an important part of it, but, you know, recruitment, you know, there's other aspects to that equation. And I'd say get the best way you can, some measure of side to side asymmetry in both posterior and anterior, and relative ratio on, you know, on one leg, on both legs, and then comparatively between legs, because it's important. That strength is an important factor. If you have to use a, you know, isotonic device, that's what you use.
Gotcha. And I'm glad you brought up strength. That was my second question. Do you know if there's any relative strength correlations with, I guess, ACL, maybe specifically in regards to knee valgus, not including the motor skill aspect of it?
Yeah, it's when you say strength, I'd have to ask strength of what?
Lower body strength. Maybe we could talk about a simple squat or one leg squat relative.
The problem you have is there's lots of confounding variables in there. Some athletes, and I alluded to this earlier, you could have a massive leg press because you have a massive set of quads, but you could have, you know, under strength, under recruited posterior chain, and you're actually at higher risk. You know, it's that it has to be, I don't think you can just say lower extremity strength.
Right.
Some of the strongest people, especially if they're front loaded, are the higher risk people.
I got one last question, just curiosity. In terms of ankle braces, it's very common. People tape up the ankles before games and there's no actual ankle issues. Does that create a potential greater risk, would you say, for the upper joints?
Yeah, so I can use this parallel analogy with that. Before ski boots, before rigid ski boots, you know, the rigid plastic ones we currently use, they were softer, you know, fabric variety. What you did is you normally, with the forces, the lever forces on the ski, you know, you're torquing the tibia, you would have tibial breaks. So that's why they came up with these, you know, big, thick, heavy, stiff ski boots. What that did is it sent the forces up the knee and resulted into lots of ACL tears. This has been postulated that, you know, people with when they first came out with those active ankles, or the ones that, you know, that are really stiff plastic constructs, people would say, oh man, I know I'm seeing more ACL injuries in my athletes, but that's never been really shown in the literature. What you have to be aware of though is when you alter that kinetic chain, If you're altering movement, it means you're altering force absorption in a joint. That force has to go somewhere else. Just be aware of that.
Thank you.
I have one quick question regarding core training. In regards to biofeedback in foot and lower limb, in regards in relation to center of mass, do you find more of a benefit from the unstable surface core training versus stable surface core training?
I think you do both, and I think you progress from stable surface to unstable surface back to stable surface. So normally what we do is we start out two-legged stable surface, then we go to single-legged stable. Then you go two-legged unstable to single-legged unstable. And then of course you're gonna have to get them back onto the field or onto the court. So then you take them back to single leg stable, but then you introduce more perturbation to their trunk from, you know, people pushing on them or balls or whatever methodologies you had for creating trunk perturbations.
Thank you.
But they're all important. I think it's, you know, you incorporate all of those in. Other questions?
Well,
Go ahead.
yeah, I can tell you that Steve and I have put each other in headlocks around the around the band training and when and where and how and all that. I'm not asking you to make us walk off 10 paces and, you know, shoot, but when and where does that happen? I mean, I see how it's applied. My take is I can see that if we're coming out of surgery, but once we can stand, and to your point, the synchronicity of all that chain happening plays a huge part, and you're not getting that when you're not just in the clamshell, say for instance, but when you start isolating certain areas, I think you're losing a lot.
Yeah,
What's your
I think isolation of certain areas with bands is early to mid post-surgical. I think that's where bands really play a role. Bands to assist on Russian hamstring curls with, you know, when you're just to get a full eccentric concentric range of contraction. But again, I tend to agree that that's post rehab, early to mid phase. You know, because you're not going to. I'm more of a proponent of free form dynamic movements that are going to activate and strengthen the musculature. But bands do definitely have a place in early rehab.
So let's say we do one of those drop tests and, you know, we get like in fact, when we do step ups, so step ups as a strength movement, we go, you know, stepping forward up onto a, you know, 12-inch plat, whatever it is. And then I always go 2 seconds eccentrically, because anybody who just kind of uses the back leg to go up and then just falls off, I mean, there's really no work done there. So we make sure the back leg's not used on the way up. It's straight, it lags, it's all lean forward and drive. And then on the way back down, you're going 2 seconds, 1,000, 1,002. We see all kinds of stuff where it just happens. But let's say that you're coming on that drop and we see somebody who's really horrible on that. Is that somebody that should be doing lying clamshells or any version of the 2 or 3?
No, you're just starting out again through that's ligament dominance, and you're starting out through a plyometric progression with a lot of biofeedback.
Okay.
Dr. Hewett, as a follow-up to that, I mean, you had mentioned cueing. Could the bands, say during a warm-up, be helpful in terms of stimulating them to kind of do that abduction, external rotation moment?
Yeah, again, like all the therapists that I've worked with use bands, especially early on, and they see that as part of the potential cueing process. The challenge is, though, you're not going to see that in a dynamic on-field situation. So I would say, yeah, early. And I think that's more of what I'm talking about with, you're going to start out internal. And then when you progress to external, then you go off other cueing.
Yeah, got it. Thank you.
Can you also mention too, like there's been some talk, recently about fatigue inducing, ACL rupture, and that's been, a few papers are out there that says that's exactly not the case. I would say that's relatively new, like to most folks.
So basically, I don't know where they teach this. I don't know if it's in PT school or AT school or both or wherever, but most people will tell you, physicians you talk to, athletic trainers, physical therapists, fatigue causes ACL tears. I always just question that, because being a biophysicist, biomechanist, what tears an ACL is force. When you're fatigued, you slow down, your velocity drops, which means your force drops. So we did a series of studies looking at everything. Matty Bourne is really an excellent researcher from Gold Coast, Australia. I worked with another group, Timmy Doyle and Kate Webster. We did meta-analyses of all the existing literature, and we showed, if anything, ACL injuries occur very early in games and matches. And it doesn't matter whether you're looking at the first quarter versus the second quarter, or the first quarter versus the fourth quarter. There's a tendency for ACL injuries to happen when you're fresh and you're really going full out, not when you're fatigued. So I don't think fatigue causes ACL injuries, both from a biomechanical and an epidemiologic perspective. And that is relatively new. When we started putting that out there, I've had some real interesting Twitter troll battles over that question. But I don't think fatigue is what causes either primary or secondary ACL injuries.
Okay. Anybody else? Are we exhausting? You got this guy right here. I'm telling you. But trust me, when I tell you, I pummel him all the time.
Yes. Yeah, I enjoy a good pummeling.
Yeah. And then sometimes I'll even say, well, this is what I think, so and so. What about you, Tim?
Fair enough. I love it. I love a good discussion. Anytime, anywhere, anyhow.
I love bringing in the reinforcement.
Yeah, if you guys want to look me up on Twitter, check it out. It's usually gets a little fun and a little controversial, but I'm usually out there.
Well, I think the biggest thing is that we're all together on this thing. We all want the same thing, and a lot of this, is it's much like sometimes I liken it to weightlifting and baseball, right? Like you still hear the same stuff about weightlifting and baseball that I heard when I got into baseball in 1993. It just kind of going until, some ass like me jumps in there and says, there's no reason not to lift overhead ever. And
absolutely.
And then you start battling it out.
But I think the important part is you just sell them on functional strength and performance. Yeah, we're going to get you stronger, but we're going to use that added strength functionally. And
then I think that, and then of course the cherry on top of the sundae for me and subsequently for all of us is like, and here's the evidence. Like I said, I know what I feel, I like, I think, I wish. We know, and that's why, Tim's been so valuable for me, because I don't need to say, what is Tim thinking here? What is this? I can find out.
I try not to say anything that does not have an evidence base behind it. I really try not to express my opinion. I try to tell people what I've gleaned from the literature. And
that's what I want us to do, whether it's ACL or, hand rehabilitation. I want to make sure that
Yeah.
we can absolutely punctuate what we do. And at the same time, you know, there's still, I mean, again, some of the lively debates we've had together, not me and Tim, but Tim and I and somebody else, is based on 15, 20 years ago, you know, like, wow. And so I want to make sure we're ahead of that game. I think we are. I think we're moving in that direction. And we got, you know, like I said, he works with Chris Power. So, I mean, we're right there. But I mean, anytime we can get somebody of this caliber to speak to us on any topic, we've got to be able to take it. And fortunately, I've got a good enough network that we can reach out and give him a call. And he was absolutely ready to go. So.
Anytime I can help, don't hesitate. Just give me a text or a call or a tweet. You name it.
Great. Well,
Thank
if there's
you,
nothing
Dr. Hewett.
else, thanks, Tim. You and I'll.
Thank you so very much. Yeah, you all take care.
I'll catch up with you
Thank
later.
you.
Okay, sounds great.
Thank
Thank you
you.
so much.
Thank you very much.
Thanks,
you.
everybody.
All right.
Thank you.
Thank you.